Do you think that PTs are aware that the RUC determines the value of their services and that is determined entirely by specialists? The RUC, which is the organization that comes up with the relative value of every unit provided in all of medical care. These are all specialty physicians. So they've weighted specialty care more heavily in terms of reimbursement, primary care lower, right? They have fewer available codes. And think about PTs. What do we get? A dozen? We get a dozen, maybe around a dozen codes that we use on a regular basis that aren't weighted very heavily. Kick it.
Welcome to Strata Stories. My name is Thomas Schreiber. I'm the Director of Marketing here at Strata PT. Strata PT is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. On today's episode, Paul Singh, the CEO of Strata PT, talks with Dana Strauss, who is a PT and the Senior Director of Government Affairs at CVS Health. Paul and Dana talk through physical therapists as the front door to healthcare, building relationships with primary care providers, the role of PTs in population health, and lastly, value-based care and financial incentives. If you'd like to learn more about Strata PT and see how our EMR and RCM works, head over to stratapt.com to book a demo. Now, without further delay, here's today's episode.
When you say PTs are a front door to healthcare, can you just talk about what that means to you?
Strictly, speaking from objectively, right? They're a front door. They're allowed to be a front door because of direct access in, I guess it's every state by now, right? I guess there's some states that, I should know this probably better. I guess there's some states that have a little bit more freedom than others, but for the most part, every state you can go to a PT. The problem becomes the payer, whether or not the payer will pay you without a referral from the physician or a prescription from the physician, which is still, that's getting a lot better too. But taking that opportunity, so we've built that over the last 20 years to the place where pretty much anybody that walks in, if they walk in your door, you can treat them at least to do an evaluation. We've not gotten that message out, not just to individuals, right? Not just to the community, but we haven't gotten the message out well enough, in my mind, to those who need to expand access for their patients. So, like, how many of the primary care providers within a geographic location know that a patient can and should, for most reasons, go see their PT when they have pain or an injury, as long as you're ruling out red flags where they would need to see a physician first? I'm going to guess it's about 1 in 100. I mean, even those physicians that I know and work with closely, for them to come out with that statement and say confidently, like, I have a patient who sprained their ankle, and if they called to say, I want to come in and see you, I would confidently tell them, no, go see your physical therapist. That's not happening. And what they'll usually say is, if they can't see you, go to the urgent care, go to the ER, or go to the orthopedist, right? Those aren't the best options. But have we, like, as a therapy community, we talk about this as if it's commonplace knowledge. It's not. The public and the rest of the providers don't see it that way, and for the most part are not incentivized to see it that way, right? And that's where we start getting into what's payer policy, what's federal policy, and what's, like, how we've been translating that message to the people in our community, right? To populations. How do populations know that this paradigm has shifted?
Again, I'm the second grader here, so you can totally make fun of me. But I think what you're saying sort of reinforces maybe the idea I'm kicking around, which is that this is almost like a marketing and messaging problem, just as much as it's probably a policy problem. In other words,
right.
Policy can affect change at larger levels, where we can say to lawmakers or rule makers, like, hey, here's the benefit to allowing more direct access in your state. But on the other side of that, even if you had that in place, there has to be some sort of marketing or messaging campaign, maybe makes the primary care doctor aware of these things, but also maybe makes the patient aware of it.
There's also, if not to interrupt you, but I'm imagining in my mind a Venn diagram between the payment incentives for example, a primary care provider to care, to even care to know that a PT can see someone they identify as that's my patient, to say, I have the right incentive to send the patient or direct the patient to this trusted PT or to that individual's PT because it's the best thing for them, rather than saying, come see me first so I can put in the CPT code to get the quick billing. And I know 99% chance I'm just going to send them to PT anyway, right? Until you shift the payment incentives, there's no incentive for the physicians to care at all. And I will argue, if you don't have physician buy-in, you're never going to be considered mainstream medicine. I bring this an idea about what behavioral health providers have done right and what I think PTs need to be doing to follow in their footsteps is identify yourself as at the same table as the primary care team and being an integral part of them, right? So and then marketing is the other part of the Venn diagram. So where does the marketing component overlay and messaging marketing, right? Communication about what we do and why it's great. Where does that overlay, where does that Venn diagram come together where we have physicians that are incentivized to care and messaging that we're ready to get out? Who are those people? And that Venn diagram eventually becomes one.
Out of curiosity, what does that look like? So, and again, I'm not a PT. I've never, been in any medical school or anything like that. So when we talk about this idea of, and I forget exactly how you said it a second ago, but when we talk about this idea of building those relationships with the primary care doctors and stuff like that, tactically, what does that look like? I mean, obviously, there's probably bigger ad campaigns and all sorts of stuff, but let's say you're a practice owner in South Florida, you got 5, 6, 10 locations. What does it actually mean to build those relationships? Is it dinners? I don't know. What does that look like?
Yeah, that's the perfect question. I think it looks mostly like, the things that we talk about in kind of content marketing. It's what value can you provide to them and who are the right providers to provide that value to. So in the simplest example, right, if I identify what providers, what physicians and APPs in my community are in alternative payment models, right? They're taking some kind of financial risk. They think of themselves as managing a population over time. If I can provide, the value I could provide to them is a couple fold. Generally, they're trying to grow their attributed population. So they're trying to grow who's part of their practice, right? Who connects with them. So they see themselves as responsible for their care. And they're trying, generally, those physicians, APPs, they're trying to encourage their patients to come back in to see them proactively. So these programs, these accountable programs, these models that physicians, especially primary care, getting into, they depend on having an ongoing connection to their patients. And if we can help facilitate a stronger connection, right? So say we're identifying, let's say they come to us first, right? And we're seeing them for a sprained ankle or back pain. But as we're going through the H&P and we're, connecting with them, we realize that they haven't been to an annual wellness visit. They haven't had their colonoscopy or their mammography done, and they haven't had their flu shot. These things, physicians are in any, even in MIPS, but physicians are judged on these things when they're in alternative payment models. And if we can say to them, oh, if you haven't had your mammography done and you haven't had your flu shot, who's your primary care doc? Let's get you an appointment. I mean, in the ideal situation, you're sharing, right? You have a connected EMR and your team is working with the primary care. So it's it's the same as just about anything else. You're showing value in the way that those that you want to build a connection with perceive value.
Yeah. In your, you've seen a lot, done a lot, that sort of thing. And you don't have to name names, but out of curiosity, is anybody doing this well right now, the way you described it?
In the PT world, no. And we're trying to, great prompt. We're trying really hard in the accountable care value-based community to get other physician specialties to do this, right? I'll give you such a great example that I heard at a conference, a very tiny little conference around value-based care last year. Kaiser Permanente came in and they were giving kind of a presentation on how they visualize the role of specialists in helping to manage preventative care. I've never heard anything like this before. What he told us was a physician, this was a primary care doc. He said, our orthopedists, our neurologists, everyone that works for Kaiser is responsible every time they see a patient for identifying what tests they've had done, like if they have missed their mammography, if they've missed any of their annual testing, they must schedule it, and we judge them and pay them based on their willingness and follow through on making sure that every touch point is a way to connect that patient to the preventative testing they need. And they've measured that in ways like, right, they have a much quicker an earlier time to identify breast cancer. Their treatment is more responsive. They have an internal system for making this a smooth process, and their outcomes are better, right? Their survival rate's higher because they empower and require everyone to be part of that patient's care. That is a very unique closed system that incentivizes in a closed loop. But it's not, that's a pay, right? The payer, it's a payer risk agreement, right? However, we can do that and providers are doing that in primary care now through the continuum. It's just happening in small amounts, and PT is not at the table yet in those conversations, right?
Yeah. It, you're alluding to this, but I just want to ask the question directly. When you've alluded a couple times that PTs are not part of this. So some people would say, okay, well, top down, somebody's got to do this for us, and whether it's some, trade organization or policymaker, there's that passive approach of somebody else fix this for me and I'll just show up. But what's the bottom up way, I guess, to do this? In other words, when you say PTs are not part of this equation yet, or, they're not sitting at the right tables, is it fair to say that the implication here is that the PTs kind of are waiting for somebody else to fix the problem and invite them to the table? And then maybe the flip side of that is can PTs do anything about this right now, ground up individually? I'm sorry, that's not worded correctly, but
I think we even step back further and say, I'm not sure, and generalizing, but I'm not sure very many PTs functioning in any setting really. But if we're talking about an outpatient PT, not sure they really can visualize the opportunity, or I will even say the responsibility that they have to be a part of population health management. And the incentives aren't clear right now, right? It's not clear. I can't tell you, if you do X, this will benefit you financially Y within X amount of time. And going back to the beginning of our recording, when we talk about something taking much longer than we ever think, there are seeds to plant now that will pay dividends, but those seeds are not one directional. So, where we can think, okay, yes, there are things that have to happen from an advocacy perspective, right? Things like the value of the PT code. So PTs have, an incentive to provide more primary care-based services that, or I don't know if that's the right word. I would say as PTs, we are paid similarly to way primary cares are paid, but primary care providers are paid, but we don't have the same number of billing codes. We have a handful, I'd say a dozen billing codes that are used regularly, right? And they don't have large values. And part of the reason that exists is who has decided the weighting of those codes. So, right. So there's certainly policy conversations happening around, in Senate Finance. The Senate Finance Committee is thinking about, well, do we need to just reevaluate the organization that determines the weight of every service, right? Do you think that PTs are aware that the RUC determines the value of their services and that is determined entirely by specialists? The RUC, which is the organization that comes up with the relative value of every unit provided in all of medical care. These are all specialty physicians. So they've weighted specialty care more heavily in terms of reimbursement, primary care lower, right? They have fewer available codes. And think about PTs. What do we get? A dozen? We get a dozen, maybe around a dozen codes that we use on a regular basis that aren't weighted very heavily. So there's that angle, right? There's what and other things PTs can do. I mean, honestly, things like offering to join an accountable care organization, just to be the physical therapy clinic that's part of an organization, sets of PTs, a health system that are PTs, physicians that are taking financial risk and accountability for a population. So they're incentivized and paid based upon the outcomes of the population. We could proactively go to the ACOs in the area and offer to join their ACO. That could look a lot of different ways. Those could be agreements, right? And I've recently found out this is happening now. There are organizations, musculoskeletal physical therapy organizations, that are going to accountable care organizations and saying, okay, we're willing to take what they call subcapitated risk. So they're saying for, any one of a number of conditions, we are going to take the responsibility for lowering what's the historical episodic spend for those conditions. So it could be things like falls and back pain and headaches, or, ankle sprains. We're going to take that responsibility. And if we do a good job, you are going to share in some of that longitudinal savings with us for doing a good job and keeping those episodic costs down. There are multiple organizations that are already formed and are musculoskeletal physical therapy organizations taking financial risk with ACOs, getting into these subcapitated agreements. So these things are happening. It's a matter of, is this just going to be something that venture capital does? And right, tech firms are picking up on, we need them to help probably lead the profession, but wouldn't it be great if just physical therapy clinics that are functioning now, that are doing a great job, are aware that this is an option for them? It's not just an option for venture capital that's figured it out.
Well, I think, the interesting thing here is, so this is a really, really interesting point you're bringing up. So first off, like, you mentioned things like RUC and relative value units, and we're going to talk about that here in a minute, because, those are terms that I've never heard a practice owner in the last couple of years even mention that in any, like, nobody knows that stuff. Like,
yeah.
And they probably
every
should.
physician does. Every physician will know what the
Right.
RUC is and the RV and the rate or the relative value unit of every one of their services.
And it's interesting, like when we think about, venture capital and technology companies sort of messing around with this stuff, the thing about it is, like, I'm trying not to sound like, Tony Robbins here or anything like that. But, the thing about venture capital on the whole is that it operates on this kind of optimistic viewpoint of what is the one thing that has to go right. Whereas a lot of incumbents, not just in healthcare, but a lot of incumbents in almost every industry, spend an inordinate amount of time thinking about the 87 ways something can go wrong. And those are, the easier way to say that is that playing to win is very, very different than playing not to lose. And so I think, the second part of this, to tie it back to what you just said, is that, you mentioned, like, and again, I apologize because you said it so eloquently, but, you said something along the lines of, like, you're already seeing PT organizations and things like that going to the ACO and saying, we'll share in the outcome and the saves, right? And so what's interesting here also is that, like, for that practice, and I've never heard any really practice owners thinking about it that way. But the point is, though, is that, like, I think so many of them are just hung up on this idea of, like, okay, what's my reimbursement per code? Oh man, it's always going down. So what am I going to do to fight to keep it up? And then when these sorts of ideas are presented to them, it's kind of like they don't understand. So I guess here's my very poorly articulated question on this. All things being equal, if let's just say an entrepreneurial practice owner wanted to go have those conversations with their, the ACO in their area or whatever it might be, is it fair to say they'd make money doing it? Like, in other words, when we say, like, it'll save costs and better outcomes, like, the underlying implication of that is, like, oh boy, I'm doing more work and not getting paid or whatever. But what you're implying is that by moving up the value chain as a PT and getting to the table, what we're really talking about here is bigger money. And I know it's taboo to talk about that in healthcare.
No,
but is it fair to say?
We provide high value. We need more of the healthcare dollar to serve the population. It's totally right to say PTs are not they're not able right now to give the amount of value because of the way they're reimbursed, and the opportunity is there right now to change that paradigm.
Yeah, because it's interesting, like, and I don't mean this with any disrespect to any of the people I've spoken to over the last year or two, but, like, one of the underlying quiet discussions that even the most entrepreneurial PT practices are having right now is they're like, okay, if I could figure out how to roll out remote therapeutic monitoring without a whole lot of rub and a lot of friction, if I could do it simply, gosh, I could get another $100 per patient, per episode or whatever. And that's big money, when you kind of run the numbers. But what you're really implying is like, hey, look, let's step up to the next larger table and share in the much larger feast. And we're all obviously taking on a lot bigger burden there too. But the way I interpret what you're saying is like most practice owners are thinking passively, like what can I scrape towards me with the reimbursements coming my way? And what you're talking about is let's go on the offense and play with the teams like these ACOs and stuff like that that are taking on that risk, and getting paid for better outcomes and lower costs. That's kind of what you're describing. I think, is that fair to say, by the way?
RTM's I will turn it a little bit because I think it's more positive than generally directionally. I think you're right. But RTM, I would say, is a good parallel to, in the physician world, services like CCM and TCM, right? Chronic care management, transitional care management, principal care management. There's a host of what some in the ACO community I've heard termed good codes. And I'll explain what that means. In most of healthcare, we think that there's an overutilization of many services. Primary care is not one of them, and mostly physical therapy is not one of them. Overused services or unnecessary services or things that they're not medically necessary. Having an MRI when you have simple back pain, unnecessary. That's an unnecessarily used code, right? But things like chronic care management, principal care management, these codes, and RTM is another one. These are codes that are doing a different service. They're not just providing a transactional service, but they're kind of the seed codes for providing kind of like if we think about in primary care, total risk, meaning they're not billing, they're getting paid monthly, and then they're getting shared savings for reducing the total spend, right? These are the seed codes for eventually, when we talk about a 10-year time period, 5 to 10 year, the seed codes for moving into full accountability. So when you realize, when I outreach and should be billing for things like chronic care management, outreach for annual wellness visits, all the preventive services, these are things that are not typical transactional medicine. They have another purpose. At first, though, they're used to increase billing for the primary care provider, and that's intentional, right? We want to shift, and payers and CMS, they are very open and honest about wanting to shift more of the dollars and the available dollars to primary care. And this is, again, where as every single year, we're seeing the payers say, we're going to shift more payment opportunities. We're going to add more billing codes. We're going to increase the weight of those codes to primary care because we want to incentivize a different kind of care and give more resources to primary care. Where's PT in that? Behavioral health is sitting right there. They're being given more codes. They're being given more independence. They're right. That I know I keep going back to behavioral health because the parallel, if you want to see it, is right there. RTM is not a bad thing. Looking to take advantage of RTM is a good way to get practice in that type of service that's not your typical transactional service like we think about PT. You come in, you get a service, you go. This allows you to do something different. So it's the seed, right? It's the seed of pop health management that's been given to PT. I would be thinking about things like what RTM is there an opportunity for the ACO to be doing that they're not doing down the road? How can I potentially, as a therapy clinic or a therapist, how can I be offering a higher value service or offering my RTM services more upstream than even me, more upstream and right to the primary care provider's office? What I would say, going back though to talking about what can therapists do now, if a therapy organization, especially one with more resources, a larger one to start with, wants to hire a data vendor to access the VDRC files, and I can't remember what that stands for, but they're 100% Medicare. Start with Medicare because we know we can get that data very easily. There are many vendors that have access to full 100% Medicare claims, right? So what you would do is you hire a data vendor and then you work with them on stratifying the spending for the population, for any population. You can just take the ACO's population, that's all public knowledge. And you can stratify that by spending that therapy can impact. So if you know that their MRI spend for that ACO, that group of primary care docs, their patients, let's say, have a higher than expected utilization of MRIs, a higher than expected utilization of neurology or of orthopedics, you can figure out an approximate ROI to you being the step in between and avoiding unnecessary care. Value-based care gets a very bad rap for being, oh, we're trying to stint on care. No, that it doesn't work. How can you provide higher value care, the next best step, right? Rather than unnecessary, higher intervention, avoidable care, if that makes sense. I know I kind of spun around there, but these things tend to be interrelated a little.
Well, and that's actually a good segue there actually to you made another comment to me about, you said PT should be reading health affairs, not just PT journals. And before I let you riff on that, I would just say one of the things I'm kind of picking up from you, I mean, you and I have only met each other a couple times now, but one of the things I'm like taking away from our conversations is that a big part of this is really just figuring out how to get to the table. Like, these PTs and these practice owners need to figure out how to get to the table.
That's
huge
right.
part of it. But the more subtle and maybe even more challenging part is figuring out the language. And so you made this comment, you said PT should be reading health affairs, not just PT journals. And to me, like my very surface level interpretation of that is that the lingo matters. And it's not like, tell me if you disagree, by the way, like if I show up to the table and I'm still talking like a second grader, I'm not going to be shooed away or anything like that. But on the flip side, if we come in with this common language and, like the words you were just using, it makes everything a lot easier because yeah. So let's talk about that. So you'd sent me this email and you're like, hey, here's an interesting article in this thing. And then you, in parentheses, as if this was not the most important point, you said in parentheses, PT should be reading health affairs, not just PT journals, which I just thought was funny because that's the bigger point. Tell me what you mean with that.
I mean, health affairs, everyone in the medical community, in the continuum, right? Health systems, every physician you'll talk to, they know health affairs. Health affairs is the intersection. It's a journal at the intersection of health policy, healthcare delivery, and the business of healthcare, essentially. That I'm not giving you exactly byline, but that's essentially who they are. And if you want to be noticed, you want health affairs to be willing to pick up your article, right? You can pay them to do a sponsored post, right? But ideally, and that's not a bad way to start getting your name out. The hint, you can pay health affairs to do an article that says sponsored post, but at least the other, like the medical community is reading it. Health affairs is an easy way to keep anyone in the healthcare community up to speed on what's happening in policy and why that matters for the business of healthcare. If there's one single thing that PTs read outside of their typical medical journals, read and subscribe to health affairs. They're talking about what's happening on the Hill. They're talking about why that, and not just the Hill, but they're talking about what the regulators are saying, but they're relating it to what they see are pain points in medicine. And a lot of it is opinion. It is opinion, right? But but then there's also research in there. So health, like I get asked that question a lot, like what should I read? And there's like loads of great websites. But if there's one thing I would subscribe to or one journal I would invest in, and it's not a really big investment, it's Health Affairs, right? It's the journal for healthcare business, healthcare policy, and kind of what the medical community is talking about and caring about. And it keeps you just ahead of the trend, right? Some are going to read Health Affairs regularly. Some know it, but like they may like read an article here and there when it gets sent to them, but they know it. If you're a PT, you want to connect with docs and the rest of the continuum. It's great if you can say you read, right? You have a chance to say, I read something in Health Affairs and it resonated with me.
Thanks for listening to another episode of Strata Stories. Strata PT is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. If you'd like to learn more about Strata PT and see how our EMR and RCM works, head over to stratapt.com to book a demo.